Greetings, everyone, and nice to see you in what is turning out, I think, to be a lovely spring. Welcome to our 34th Town Hall conversation today. We've got a really interesting one today. We're joined by Dr. Mas Takashima, who's chair of our Department of Otolaryngology and Head and Neck Surgery. That's the medical specialty that focuses on ear, nose, and throat, and we'll be talking about a couple key topics in that area. As always, I want to recognize the members of our Society for Leading Medicine for presenting these great programs, as well as our chairs, as always, Dr. Waverly and Adam Peaks, and Kristen and John Berger. Thank you to each of them for chairing this great group. We're also joined at my left by Dr. Jeff Vrabeck, my apologies, who's Division Head of Otology and Neuro-Otology. So otologists are people who study and treat the ear, and neuro-otologists specially trained in both the ear and the brain. So a lot of hearing work that you will come from there. He's going to focus on cochlear implants, although he will also answer many other questions about the ear and hearing. As always, if you're interested in this, we invite you to participate. We've already taken some questions in advance. You can always text the word DeBakey to 37607 and ask your question. You also can post in the live stream chat. We have Dr. Ben Lovin, one of our otology fellows, who will be there to answer your questions and be typing fast and furiously. So with that introduction, we're going to turn things to Dr. Takashima, who's going to talk to us about sleep apnea, which sadly is probably far more common than almost everybody realizes. So thank you, Dr. Takashima.
Mark, and thank you, everybody, for being here today. I'm going to start off with just a simple statistic. 1 out of every 2 people has obstructive sleep apnea of some sort. Now think about the significance of that. Every other person that you see has some form of sleep apnea. And so, if you think about the fact that it is known that sleep apnea, especially untreated sleep apnea, can shorten your lifespan, what else is considered a national emergency? Considering the fact that the incidences and prevalences of sleep apnea is only getting worse. And so today, in the limited time that I have, I'll be talking more about the surgical management of obstructive sleep apnea. And so for patients that just didn't tolerate CPAP and medical management of their obstructive sleep apnea, then they will see an ENT surgeon, ENT doctor, to help guide them in regards to the surgical management of what's out there, because we really want to personalize the treatment of our patients with obstructive sleep apnea. And so, whenever we talk about sleep apnea, it's interesting because we always talk about the patient that has sleep apnea. But I'm sure there's a lot of people in the audience that will say, hey, my spouse has sleep apnea, but I'm the one that's suffering. We hear that all of the time. And there's actually studies out there that show that if you treat the snorer, the sleep apnea, then the quality of life of the spouses actually gets significantly better from a physical well-being, vitality, social functioning, emotional and mental health. And so, we also want to look at, can sleep apnea cause other medical problems in the spouses or significant others? And so, Exhibit 1. Here's Mel, all right, 92.5 decibels, okay, is the sound of his snoring. Now, if you compare that to the sound of a rushing subway, train going right by you, it's just barely less than that, or a raging ambulance, rushing by you. So that's the significance of the amount of sound that a snore can actually make. And if OSHA came by, Mel's bedroom, OSHA would tell Mel, hey, your wife can't be in this room for greater than 5 to 6 hours, because if you snore like this, your wife is going to have some hearing loss. And, is there any credence or credibility to that? Well, there actually is. There are some studies that have looked at this, and as you can read here in the small print, it says, bed partners of snorers in our study demonstrated unilateral high-frequency pattern of hearing loss consistent with noise-induced hearing loss. Furthermore, the affected ear in every case was the one that was claimed to be chronically exposed to the snoring noise. So definitely some data there, and I'm sure Dr. Vrabeck will be talking a little bit more about that hearing loss, so that would be a good segue to that. Now, if we talk about the continuum of sleep disordered breathing, so as you can see on the left of the screen, normal breathing, then it goes to occasional snoring, then constant snoring, and then sleep apnea occurs when there's snoring, then all of a sudden there's a pause for at least 10 seconds. And that pause occurs because the patient is not breathing, so it's not passing air, okay? And so there's no vibrations, and the more severe that becomes, you get mild, moderate, and severe sleep apnea. So how do you differentiate snoring versus sleep apnea? Really, the only way you can do that is with a sleep study. Before, you had to go to an in-lab sleep study where you're wired up, throughout the night in an unfamiliar environment with someone watching over you. Hard to sleep that way. Nowadays, we have home sleep studies that are a lot more comfortable for patients and respecting their privacy, so much better. So the reason why we really want to differentiate snoring versus sleep apnea is because there's a lot of potential medical complications associated with sleep apnea. So, as your oxygen level drops down, your body, quote, freaks out. It's like, hey, I'm not breathing, I could potentially die. And so what then happens is that the body then releases a lot of adrenaline. And then that adrenaline raises your blood pressure. It can cause cardiac arrhythmias, and long term it can cause congestive heart failure, and the high blood pressure can also cause strokes. Now, on top of that, the body releases the stress hormone cortisol, which then can lead to trouble maintaining your sugars if you're a diabetic. It can also cause sexual dysfunction. It causes the body to create more fat cells, and so obesity is prevalent in this population. But on top of that, a lot of mood disorders too. But the most important thing is that if you look at long-term, that graph, that red bar there, shows patients with untreated severe obstructive sleep apnea. So if you look at long-term, greater than 15 years, your chance of survival declines pretty precipitously if you have severe sleep apnea. And that's the reason why we really want to treat the patients with severe sleep apnea and even those with moderate sleep apnea as well. Now, the problem with sleep apnea is that the incidence is continuing to get worse. Why is that? Well, look at global obesity. Okay, if you look from 1995, I believe that says up there, all the way up till now, what we're seeing is a continued progression of obesity throughout our country. And so what started out as only about 15%, now we're doubling it to at least 30%. And last year, the CDC said that approximately 40 to 45% of all Americans are now obese. And so that's a big problem, So the evolution of how man is evolving is changing to some degree. So what other things are important? Well, it's the increasing age of the population. So if you can see on that blue line right there, you can clearly see that the patients greater than 65, or the population greater than 65, is continuing to increase, while that red line there shows that the population under 65 is precipitously decreasing as well. And so, as we would expect, the prevalence of obstructive sleep apnea is continuing to rise in a linear fashion. At this point, if you look at the chart on the left, males, about 60% of the population has some sort of obstructive sleep apnea. Obviously pretty significant. And if you look on the other side, females, similarly in a linear fashion, it's increasing, but about 10 to 15 percentage points lower. And so briefly about CPAP therapy, if you think about the treatment of sleep apnea really didn't occur into the 80s, and to me that doesn't sound too far away. The way it was developed initially was a doctor, Dr. Sullivan, who was treating his bulldog who had obstructive sleep apnea, so he contracted a thing with a leaf blower to actually keep the airways open, and that translated into what we currently utilize here today. So first-line treatment for sleep apnea, it is very effective, but the problem is that the compliance rate really is not great. After 1 year, the compliance rate of using CPAP is about 50%, and that drops precipitously at 3 years at about 30%. And so like I mentioned, before the 80s, sleep apnea really wasn't treated, and the only treatments was for really severe sleep apnea, where a tracheostomy was placed, a breathing tube in the neck, to bypass all that floppy tissue in the back of the throat. But obviously, a lot of people did not want to be walking around with a tracheostomy. And so if you look at this graph here, from about the 80s until now, there's been over 20 procedures, developed for sleep apnea, with the latest one being the hypoglossal nerve stimulator, which we'll talk about here in just a second. But the fact that there's so many procedures out there for sleep apnea is not really a good thing. What that means is that every procedure that was invented wasn't really doing the job, and so more procedures had to be developed. And so hopefully the hypoglossal nerve stimulator is the ray of shining light here for us. And so as a surgeon, how do I decide what surgeries to perform when there's so many procedures out there, as well as so many different anatomical areas that could potentially be collapsing? And so what we've been really pushing and really studying is trying to identify the site of obstruction. So, just because a sleep study shows that you have sleep apnea, it shouldn't be a cookie cutter algorithm. Everyone is different. We really try to personalize the treatment of our sleep apnea therapies. And so we published a paper early on showing drug-induced sleep endoscopy, a novel technique to guide surgical planning for obstructive sleep apnea. And that is definitely catching on right now because everyone who actually is going to undergo an Inspire hypoglossal nerve stimulator has to have a sleep endoscopy. That is one of the indications that is required. And so I'm very happy to hear about that. Now, as you can see here, there's different areas that can collapse. It could be the base of the tongue, it could be a little flap of tissue here called the soft palate, or even the epiglottis. And those are all the areas that we'll be looking at with this sleep endoscopy. So we'll pass a camera into the nose here, then take a look down in this area. And so just out of familiarity, I want to just point out areas that we address are the tonsils, the back part of the tongue, the soft palate, and the uvula. So all these different areas, we'll look down there, identify, and treat appropriately. And so this is just an example of a sleep endoscopy. And you can see the airway there. Then you can see this big tonsil sort of really blocking the airway. And so all we really needed to do with this patient was take out his tonsils. His severe sleep apnea completely resolved. He didn't have to be on CPAP. It was a great solution. Here's another example. The uvula, just that little dangling thing back over here, as you can see. As you can see, it's just prolapsing into the airway and blocking the airway, causing a lot of snoring and moderate sleep apnea. So we just trimmed that down, and next thing you know, the patient's sleep apnea was gone and snoring was significantly better. And so we're going to skip a couple of other areas that we addressed and really focus on this base of tongue because there's a lot of interest in that. And here at Houston Methodist, we are very fortunate to have all the latest technologies to treat this area, which is a very difficult area because it's right at the very back part of the tongue. And so we were one of the first institutions utilizing the Da Vinci robot. And as you can see here, back then, we were using this big robot trying to get into the mouth, which was very difficult to do. And currently we have this single port Da Vinci robot right here, which is a lot more elegant, as you can see, a lot smaller. We're able to get into small little areas, much better, to get better patient outcomes. And Houston Methodist Hospital is actually one of the institutions. There aren't that many institutions out there with these single port robots, so we're very lucky to have that here as well. Now let's talk quickly about the hypoglossal nerve stimulator. I'm sure all of you guys have seen this ad where this guy pushes this green button and all of a sudden the sleep apnea is gone. And so the hypoglossal nerve stimulator the research started in the 1990s, and so a lot of research has gone behind that. And FDA approved this in 2014, and at that time we also had a news release in the Houston Chronicle in 2014. So as you can see here, right when it got FDA approval, we were at the leading edge of really promoting the hypoglossal nerve implants. Now there's been over 20,000 implants already been implanted, and it is a less invasive method of surgical therapy. And the way it works is, as you can see here, there's implants right here. There's a lead that goes down to the chest. There's also a stimulating lead that goes up to the nerve itself. And so when the body is trying to breathe, the sensing lead realizes that, and it sends a pulse to the tongue, and it stiffens the tongue up so that the airway will then open up. Really interesting invention here. And so what's the inclusion criteria? So you have to be at least 18 years old, as you can see here. Your BMI has to be less than 35, and so you can't be severely overweight. And you have to have moderate or severe sleep apnea. Now, here at Houston Methodist, of course, we like to push the boundaries here even more. And we have the capabilities, and we're utilizing these 3D, 4K, beautiful magnified surgical sites. And so we can have two surgeons looking at different cameras, different monitors, and really pinpointing the placement of these cuffs onto that nerve to get even a better result. And so we'll be publishing that study here shortly as well. Now, what about 5-year outcomes? It's amazing. If you look at all these charts, 5-year, if you follow these patients, their AHI, or their severity of their sleep apnea, decreases pretty significantly, and it actually stays low. Quality of life metrics also really is very stable over a 5-year period, and the success rates about 75 to 80%. So really good results from these studies. And so what about future endeavors? And so, here at Houston Methodist, we have these amazing surgical training sites, especially Mighty, where we are actually training sleep surgeons from around the country to do all of these newer procedures. We're currently engaged in an FDA trial looking at the second generation hypoglossal nerve stimulators, and we're training surgeons to actually implant those here at Houston Methodist. But on top of that, we're also doing some really cool, innovative things such as virtual sleep endoscopies, where we're trying to use vibrations and sounds to just identify where that blockage is occurring, rather than having to place a scope down someone's nose to look at those areas. And we're also looking at using cryotherapy to shrink the fat in the tongue, similar to how cryotherapy is currently being utilized for the body. And also we're looking at bilaterals. If you stimulate both hypoglossal nerve stimulators, both hypoglossal nerves, do you get a better result? And so all these things, I'm fortunate to have the support here at Houston Methodist to have the capabilities to really push the boundaries of sleep surgery. And I'm very happy to be here today to be able to talk about some of these things that we're doing. And so with that, I would like to go ahead and pass it off to Dr. Jeff Brabeck, who will also be talking a little bit more about hearing loss.
Thank you, Moss. And the focus of the talk today is going to be about cochlear implants. But just as Moss was talking about the incidence of sleep apnea in the United States, hearing loss is a very common problem as well. And so when you look at my slides not advancing. Now, there we go. Okay. This data shows the National Health and Nutrition Examination Survey from 2012. And what they did is they took a broad segment of patients and did hearing tests on them. And what they found was that if you look at all adults between 20 and 69, about 14% of people had some measurable hearing loss on the audiometry. However, the hearing loss increases with age, and so that if you take out the age 60 to 69 patients, approximately 40% have measurable hearing loss. And unfortunately, if you look at older age groups, you would see that number continue to increase, so that hearing loss certainly is more prevalent with increasing age. Now, this survey, I still don't have controls. All right, use that one. All right. Still don't have it. All right, there we go. So on this, the National Health Interview Survey from 2019, these are studies that are conducted by the CDC where they interview patients about different types of health conditions. And so these particular questions related to hearing loss. And so what did the patient think of their hearing? Approximately 17% of people would identify that they had a hearing problem. And about 2% of the individuals said that it was very severe. Now, of those patients with hearing loss, about 30% of them were wearing hearing aids. And why aren't the rest of them wearing hearing aids? Well, there's obviously a number of different reasons. Number one, some of them, their hearing loss is not severe enough to warrant the use of a hearing aid. Some of them might not like the cost of the device. And then there are other people where their hearing loss is so severe that the hearing aid is ineffective. And that's the group of individuals that we're going to concentrate on for the rest of this particular presentation. So what causes hearing loss? Obviously, many different things can cause hearing loss, but when you get down to the nuts and bolts of it, a lot of the hearing loss can be tied to dysfunction of what's called the cochlear hair cells. And so when a sound comes into your ear, it hits the eardrum and then goes through the little bones in the ear and creates a fluid wave within the cochlea. And so the movement of this fluid in the cochlea causes what is called the basilar membrane to move up and down. And so on top of the basilar membrane, you have the hair cells, which are basically pressure sensors. And the inner hair cell is the predominant sensor that will send a signal to the auditory nerve. And as the brain receives that signal, it identifies it as a sound. Now, the problem is, though, that this is a very delicate engine, if you want to think of it that way, and so that if something happens to the hair cells or to their accompanying supporting cells, then the power of the system will break down. And you can have problems that are due to loss of the hair cells, loss of the supporting cells. You can have problems that are due to misconnection between the hair cell and the hearing nerve. And ultimately, a lot of these will result in actual loss of the hair cells. And so if that sensory cell is damaged, it does not regenerate. And so it ends up being a permanent inability to sense the pressure waves that are occurring. Now, as a result, you have different options for how to improve the hearing, but in patients with severe hearing losses, what we will do is what's called a cochlear implant. Still not advancing on my slides here. So what's a cochlear implant? A cochlear implant is electrical stimulator of the hearing nerve. And so the cochlear implant consists of both an external component, which looks like this. It's a processor that's worn behind the ear with a coil that connects to the internal component. And so the internal component is a device that we implant underneath the scalp. And it has a wire that runs down into the cochlea. Now, the implant will pick up sounds, and the processor will convert those sounds into a series of electrical pulses. And the pulses are relayed to the internal device, which is a signal generator that will stimulate the nerve directly. Now, the concept here, though, is that as you put the implant in and you stimulate, the current from the implant goes directly to the auditory nerve, all right? And so we can bypass the hair cells, which are the predominant source of dysfunction. Once we get a clear signal coming to the brain has a better chance of being able to understand what that signal means. So who's a candidate? Again, as I mentioned at the beginning, it's the individuals with more severe hearing losses. And so on this hearing test, everything below the red line represents the types of individuals who are receiving the cochlear implants. And on the chart, the y-axis is the intensity of sound in decibels, and the x-axis is the frequency that is stimulated. Most hearing losses affect high and middle frequencies more than low frequencies, and that's why you see the difference in that line. But the most important thing is how well can you understand a sound? How can you understand a word that's being said? And individuals who start to score less than 60%, even with their hearing aids, that means you're missing basically every other word. And obviously that has a big impact on the ability to follow a conversation. Who's receiving cochlear implants? implants have been around for a long time as well. And so first cochlear implants were introduced in the 1980s. And over time, though, as there have been developments in microelectronics and semiconductors, the ability for the implant to process sound signals faster and to deliver more complex electrical signals to the auditory nerve has improved, but that also enhances the results of the device. And what has happened over time, though, is that the implants got better. The criteria for implantation have expanded. But now, the predominant groups that are receiving the implants are not the children with congenital hearing losses, but rather the adults with acquired hearing losses. And one of the fastest growing segments would be the patients over age 70. Can you receive an implant at any age? Yes, you can. My oldest implant patient was 94 when she lost her hearing. And she lived to 104, so she got plenty of use out of her device, and it made a huge difference in her quality of life. Well, how does a cochlear implant sound? Well, it's clearly not the same as your normal hearing. We can certainly stimulate different populations of the auditory nerve with the various electrodes on the implant, but it's not the same as the remarkable capability of your own inner ear. So the advantage here, though, is that if I can get a clear signal to my brain, it has a better chance for understanding a word. If the hair cells produce a distorted signal to the brain, then it almost doesn't matter how loud the sound is, you still can't make sense out of it. Now, speech is quite complex, but not quite as complex as musical composition. And so the implants work very well for speech understanding, but learning of new music is hard with an implant. Cochlear implant requires surgery, and the surgery itself is an outpatient procedure. We have to make a small incision behind your ear in order to create a channel for the electrode to go through the mastoid bone into the cochlea. The surgery is an outpatient surgery, takes a couple hours, and usually you can return to most activities with just a few days of surgery. And these other pictures demonstrate what the cochlear implant looks like when someone is wearing it. So you can see the processor here behind the ear attached to the coil. It can be hidden by your hair if you have longer hair. Not me, but other people. What are the risks of surgery? Obviously, all surgeries carry some risk, and the predominant risk of surgery with cochlear implants is dizziness. Most of the time, this is transient and will resolve within a few weeks. Pain is usually very limited, and if there is residual hearing in the implant ear, typically that would be lost as a consequence of the implant, and sometimes after surgery, but sometimes years later. The cochlear implant takes time to get used to. As with any new sensory stimulus, the brain will have to adapt to it. And we start use of the implant about 2 weeks after the surgery. And once you turn the implant on, there is immediate awareness of sounds. But now, because you're hearing the sounds differently, it takes a little bit of time for the brain to associate the sound with its interpretation. And so understanding that the door is slamming is quite easy, but understanding what someone is, when someone is speaking to you, takes more practice. But the speech recognition will improve with extended use of the device. And how much benefit is gained? Well, when we're selecting patients for surgery, our intent of the surgery is that the implant is going to outperform their hearing aids. And typically that does occur, and so that is our definition of success with the device. Now, there's a number of patient factors that will influence the ultimate benefit, but obviously number one is how much of the time are you listening to speech during the day. And the person who is hearing more conversations is going to adapt to the device much faster than someone who's not listening to speech on a consistent basis. And it's as simple as counting how many words did you hear today. The more words that someone's hearing, the more times the brain is getting a stimulus that will help teach it the difference between the electrical hearing and their original hearing. There are limitations to the benefit of the device, and one would be cognitive impairment. If the brain has difficulty learning, well, then it's going to have difficulty learning the implant also. And so we want to take that into account in selecting our implant recipients. So next steps to selection of implant candidates. Obviously, we want to measure the hearing to see how it compares to that chart I showed you earlier. We would do imaging studies to visualize the inner ear and auditory pathways to make sure that they're amenable to surgery. We do aided testing to document the maximum performance of the hearing aid, because that's our threshold. Whatever you get with the hearing aid is what we have to beat when we put in the implant. And so we want to take an accurate measurement in determining canesthesia. And then finally, we test the inner ear balance system, because in order to minimize problems with dizziness, you want to verify which ear, or if the ear has any pre-existing balance dysfunction. And so thank you. I'll turn it back over to Mark.
Thank you. Well, thank you, Dr. Braybeck. Thank you, Dr. Takashima. Two very interesting topics, and have gotten a number of questions from you all, and I'm going to try and bring a little organization to some of them. I'm going to start just following on to some hearing stuff. This is going to be more my question right now, but I mean, I'm a primary care physician, so I'm kind of guiding people through many, many different things. It seems really easy to say, just pop over, see an optometrist, ophthalmologist, they'll take care of their glasses. A lot of people sort of resist taking care of their hearing issues, maybe don't recognize or acknowledge their hearing issues. Talk a little bit about that.
Well, it is a type of problem when you go from not using a hearing aid to a hearing aid. Now you've just identified for everybody else in the room that you have a hearing problem, right? Hearing loss is invisible until I put a device there to help with my hearing. So it is a kind of a type of hidden disability.
But
However,
I would say, so are glasses, but
right.
People just sort of readily go to their reading glasses when they're in their 40s or early 50s or whatever that is. It doesn't seem like they do the same.
Which is true, but it depends on the individual's perceived handicap of their hearing loss. And you have to remember, as the brain is losing hearing, it's adapting to the new level of hearing. And so people will start to listen and take their cues from different parts of the speech sound and different parts of the word than if they had all of their hearing. As you go back to hearing aids, it reintroduces some of the high frequency information that maybe they've been missing for years, and but it takes that experience before someone knows how much they were really missing and how much difficulty they were having with following the conversation. So it is often family members that prompt the individual to come in and get their hearing tested.
Great. So I mean, I guess some vision loss, particularly around reading, seems almost inevitable just as you get older. Is hearing loss kind of inevitable? Is it going to happen to everybody, or can we prevent it and never get to that point and decrease those percentages we're seeing in the older population?
Well, it's not inevitable, and so my 95-year-old mother-in-law has perfect hearing, and so if you have the right genetics, your hearing is going to be preserved. Mm-hmm. Unfortunately, we don't get to choose our genetics, and so hearing loss is a very common genetic condition, and it does progress with time. So that's why we ended up with those prevalence figures that we talked about, that a lot of people will get hearing loss, but not everybody. Now, the preventable part of hearing loss is really environmental noise. And so that would be the one thing that you can focus on. But the activities with the highest intensity noise are typically shooting, and indoor use of power tools. Maybe you're a woodworker or something like that. Those are the types of activities that really are threatening to the ear.
And for protecting your ears in both of those scenarios,
yes.
What's the best way to do that?
The more hearing protection, the better. If I went to the gun range, I would have my insert earphone and my earmuffs over top, and so that anytime you're putting in these devices, they're dampening down the incoming sound by 30-40 decibels, which will dramatically reduce the chances of that being a damaging hearing loss.
So what about headphone use? Obviously, those are very prevalent this day and age. Is there a safe level of use? Is that any different to listening to music or other things without a headphone?
Right, and it depends on, you can look up the maximum intensity level for your earbuds, and oftentimes they're no more than about 80 decibels, right? So if you think about it, probably not going to be a significant source of hearing loss. And so typically, I guess if I could hear your AirPod playing over here, then it's probably too loud. But on the other hand, most people wouldn't tolerate that 80, 90 decibel sound in their ear for a very long period of time either. So I generally don't think of the earbuds as being a threatening source either.
Great. Well, that's reassuring for many people, I think. Probably many who worry about their kids and use of headphones from the time they were very small. In theory, if there was a difference in headphone, any difference between like some of the new bone conduction ones versus the ones that basically go through the air? Is there any difference, or is it ultimately the same common pathway into the cochlear?
Ultimately, it's how much power is applied to your hair cell, and the bone conduction devices are nice because it allows you to hear your chosen music, let's say, and still hear some environmental sounds, and so that's a nice development. But yes, it's ultimately how much power is there. So the more amplification there was, then in theory, some risk to the sensory cells.
Great. Well, that's very helpful. Thank you. Well, I'm going to shift a little bit to sleep apnea, also a very common problem I see a lot in my clinic, and I will say, I started practicing in the early 90s, so this is one of those things that's been recognized more and more and more, and I mean, every time I suspect sleep apnea, I don't think I've probably I'm not seeing enough people if every time I suspect that they're all positive, it seems like, once they tell me they're snoring. But get into that for the person who knows they snore, or whose spouse is concerned about their snoring, or the primary care physician who's seeing them in the community. When do those people need a sleep study? What's the trick? I mean, obviously, if they sit there, well, I hear them snoring, and then they gasp and they stop breathing, that's easy, right? But just they're a really loud snorer. When do you need that sleep study?
Absolutely. I get asked that question quite frequently, and there's not a really great answer. But that being said, there are certain things that you can look for. So, snoring itself is like an alarm. The alarm is blaring, hey, I have resistance in my airway. And so if you think about, if we just go in there and we stop that snoring, that's actually a problem. You're just turning off the alarm without really treating the problem. And so, if you have a lot of symptoms of sleep apnea, of course, snoring, for the most part, most people who have sleep apnea will also have snoring. And so, for the most part, the snoring is definitely something that we look for, and the degree of snoring, of course. But on top of that, genetics plays a large role. So if your mother, if your father, if your siblings all have sleep apnea, chances are, the way you were developed, you're probably going to have sleep apnea too. And so that's also another thing to consider. But also we look for other signs. Are you tired all the time? Are you, do you have trouble with any sleep issues? Do you fall asleep and then are you waking up? Is your wife, constantly nudging you? Things of that nature. Do you have high blood pressure? Do you grind your teeth at night? Do you have to go up to use the restroom frequently throughout the night? Those are all potential signs of sleep apnea. And so if you start seeing anything like that, just get a home sleep study at this point. Home sleep studies are so minimally invasive, so to speak, at this point in time that, that's really the only true way to really differentiate snoring from sleep apnea.
So even getting up to go to the bathroom frequently, so that's because you're not as in deep a sleep, and so your body kind of senses something it otherwise would ignore for longer?
Yeah, partly, but also, with all that adrenaline rushing through your body, your cardiac output.
You diurese a little more.
Exactly, you're pumping more blood, the kidneys are filtering more of your blood, and so you're actually creating more urine, and so then you have to go
Interesting.
frequently.
Interesting.
Yeah.
So tease that out a little bit, because historically, of course, it was you come into a lab, you spend the night. I mean, it's a nice place, but it's it's hardly a normal night's sleep, and
Sure.
everything else. One of the advantages, they can fit you for your sleep apnea equipment halfway through if they sit there and say,
True.
you've got sleep apnea.
Yeah.
Talk about when you make the decision to put somebody in a sleep lab versus some of this home sleep apnea monitoring.
And so the FDA, a few years ago, they approved home sleep studies as a really good way to diagnose obstructive sleep apnea. And they've done a lot of studies comparing in-lab sleep studies versus home sleep studies. And so, for the most part, just for the routine diagnosis of obstructive sleep apnea, I think home sleep studies are great. Post-surgical results, if you really want to see how well your surgery from sleep apnea worked, I think the home sleep studies work great. But if you have comorbidities, cardiac issues, pulmonary issues, or, strange variations of obstructive sleep apnea, if it's more central sleep apnea where the brain is not telling you to breathe, things of that nature. So if you start suspecting that night terrors, sleepwalking, other things that we might want to measure your brain waves, then we would divert those patients to a in-lab sleep study.
So you're worried as somebody whose spouse or whatever, and you agree, okay, you're going to go get a study. They come see you, they see the primary care physician. Most of the time nowadays, they're going to order a home study, is what you're saying. Not all the time, but most of the time. Mm-hmm. What then? Okay, so that shows you have moderate or severe degree of sleep apnea.
Sure.
Walk me through what's going to happen to that person in terms of diagnostic evaluation, and then how you make those treatment calls of which path to go down.
Absolutely. Well, early on, before we really started delving into the surgical management of sleep apnea, if you brought a sleep study to an ENT physician, they would look at it and say, oh, you have sleep apnea. We're going to take out your tonsils. We're going to elevate your soft palate, and that's going to do it for you, Nowadays, we're definitely personalizing that medicine much more. We really want to identify what is the problem. Is it the tonsils? Is it the tongue? Is it the epiglottis way down here? Or is it a combination of things sort of playing a role in causing the sleep apnea? And the reason why that's important, not only to get a better surgical result, but also you don't want a surgeon operating on an area that's not involved. And if you're just guessing, try to figure out where that obstruction is occurring, there is a good chance that we'll be operating on an area that doesn't need to be operated on. And as you can imagine, the dynamics of swallowing is so complicated. It's very, it's very, one part starts swallowing and then a different part moves. It is a very complex mechanism. And so you really want to mess with that as little as possible. Mm-hmm. And so really directing the flow of exactly what you need to do, identifying the site of obstruction, then really operating on that side of obstruction.
But so how do you first make that decision of a CPAP machine versus those who need surgery? Yeah,
so for the most part, we do recommend CPAP or medical management because, in my mind, least is better. And so if you can get away with, the treatment of sleep apnea with a non-surgical technique, then great, and if you're happy with that, wonderful, just keep doing that. It's really those patients that either, can't tolerate it, they're claustrophobic, and they move around quite a bit at night, or there's also a subset of the population, such as college students or truck drivers that don't have electrical plugs, or people that are young, constantly dating at this point, the chance of them putting on a CPAP every time they go to bed is probably going to be pretty low. And so you also have to think about the social dynamics of things too.
Interesting. Well, thank you. That's very helpful. It actually brings up a question someone asked here of how interchangeable these things are. Somebody said, literally, I inherited my father-in-law's sleep apnea machine, and I have sleep apnea. Can I just pop it on and figure out the settings, or could that be harmful to me around that? So.
Yeah, and really not harmful per se, but these machines are set for that particular patient. And so a certain pressure that machine is set on may not be enough to open up a person's airway, or that pressure might be way too strong for that individual, which makes the compliance a lot less in terms of the patient using that CPAP on a regular basis. And so that's sort of the reason why you really want to fine-tune those machines just for that particular person who has that sleep apnea.
Okay, good advice. And then finally, does Medicare cover CPAP machines was one of the questions we got.
Yes, Medicare covers CPAP machines.
Not an issue, right? Exactly. So, okay, well, good. Well, I'm going to switch back On the hearing side, got a couple questions from people, but let me change gears on something. Well, let me ask this one, and then I'll change some gears. But how do you tease out hearing aid versus cochlear implant, and how could somebody know if a cochlear implant is going to be helpful in their particular situation?
Well, much like the approach to sleep apnea, the simpler thing to try to do first is to wear a hearing aid. And most of the cochlear implant recipients, you would have to say, are failed hearing aid wearers. They might have been wearing the hearing aid for a number of years. It might have been wholly appropriate for quite a long time. But as their ear degenerated more and they lost more hearing, you end up in a situation where the hearing aid isn't good enough. And so that's why we do the aided testing to kind of see if we can determine what is the maximum benefit that this person would achieve with their hearing aids. And so as you do the test, if, again, their understanding ability, even at appropriately fit hearing aid, appropriate amplification, they still can't get even 60% of the words correct, that's the individual that we start to look at as a cochlear implant candidate.
Great. Well, that's very, very, very helpful for everyone as well. And then I'm going to wrap up just one last question for you that somebody asked. Talk about central sleep apnea. Somebody's asking about treatment for that, and explain to everybody what that is. It wasn't really in your topic, but since somebody wanted to hear about that.
Of course. So central sleep apnea is interesting. The brain, for some reason, just fails to send signals to tell you to breathe. And so obviously, if your brain is not telling you to breathe, then you're not going to breathe. And so it's very different from obstructive sleep apnea. And so just as that term obstructive means, there's something anatomically that's obstructing the airway and causing you not to breathe. Obstructive sleep apnea is much more prevalent than central sleep apnea. But it is those central sleep apneas where you really need to get that in-lab sleep study, because it's not measuring the same things that we're measuring in terms of obstructive sleep apnea. With obstructive sleep apnea, we're measuring how much the chest is really trying to breathe in, and you're not getting any airflow, versus central, where the chest isn't even trying to breathe, and thus you're not getting that airflow. And so, from a management standpoint, it is definitely different. With obstructive, we want to resolve the obstruction or the resistance in the airway. In central sleep apnea, we actually have to promote breathing. And so there are certain CPAP type machines that will actually breathe for you on a regular interval. And that's really the mechanism of treating central sleep apnea.
And why does central sleep apnea happen? Who might suspect that, and why does that happen?
Yeah, we're not quite sure. We do know that if someone has really severe sleep apnea, then that just sort of completely messes up the mechanism of breathing. And so patients will also end up with some central sleep apnea episodes too. But from a purely central sleep apnea standpoint, it's more of a neurological issue.
Great. Well, thank you both. I'm going to give you just a very quick Houston Methodist update, and I've got one question came in about COVID as well, and COVID vaccines that I want to be able to address as well. Just my updates today are kind of all in the category of when we focus on the excellence, when we focus on our vision for the second century of unparalleled safety, quality, service, and innovation. The awards tend to follow, which is always a nice thing, but it is fun to celebrate those kinds of things. So, I've told y'all before, I think I've decided that every former magazine has figured out the best way to actually stay alive is to do survey after survey after survey, so they are proliferating everywhere. Newsweek has, for the last couple of years, been doing a world's best hospitals, right? Trying to differentiate itself from U.S. News, which is doing U.S. hospitals, and just very happy to say, yet again, Houston Methodist Hospital, our academic medical center, was on that list. And if you look at where we are within the context of the United States, not too different really from U.S. News, different measurement methodologies, frankly, but just a nice thing to kind of keep an eye on. Here's another interesting award and accolade, and kudos to the team you see here. We actually were up in Austin at the Texas Medal of Arts Awards, and the Center for Performing Arts Medicine actually won their inaugural award around health-based, arts, and something that we've really pioneered and really dramatically led around the country. So they had a great time there. They got to rub elbows with a lot of superstars, music stars, and others. Sounds like they had a really great time, and I couldn't be happier for them and more proud of them in everything that they've done as well. When we focus on telemedicine and some of our innovative developments over time, we very recently won an award from essentially a national association associated with telemedicine. Very proud of that. Our teams have really both been leaders in what we think of as classic telemedicine. You get on and you do your primary care visit or maybe a follow-up visit after surgery with one of my colleagues here at the table or whomever else that is. But we're really pushing and pioneering many, many other uses, from virtual ICU to virtual nursing, where you're actually adding to and enhancing the on-site nursing, to tackling how do you handle a high fall risk patient in the middle of the night, and do that perhaps with some remote monitoring that's actually more effective and more cost effective, but also more effective than sticking a single person who's sitting at a bedside and probably dozing off during the night. And so very proud of that team as well with what they've done. And then just a neat one, this isn't an award, but just a neat thing that we're doing. We are partnering with Axiom Space to work with them on fit for mission assessments, athletic training programs, pre and post mission. So really continuing our focus as we begin to see space obviously become much more than just NASA, and obviously the privatized component of space. So lots of interesting things happening here at Houston Methodist. So those are my updates. I did get one question about COVID vaccine, and it's specifically somebody saying, my wife and I are in our mid-70s. We had our bivalent COVID vaccination in September of 2022, so 6-ish months ago now. We're planning to travel internationally and domestically starting in April. Should we be considering getting another booster? This is a question a lot of people are asking out there. So let me, and I'm not going to be able to give you a crystal clear answer. It's going to be a little bit individualized, but I'll try and give you overall guidance for that and where I think things will go. Again, kind of polishing off the crystal ball. First off, if you look at the status of COVID in the United States, knock wood, we're in a pretty good spot right now. Our wastewater levels are not the lowest they've ever been if you look at Houston, but they're pretty low. Our hospitalizations, when we look at that as an indicator here, are hovering right around 100. We got down to maybe 45 or so, I think, in September, but still, this is kind of a significant nadir that we've seen. The question, frankly, we're asking ourselves in terms of the time course of COVID is, we've seen summer surges in the southern parts of the United States each of the last couple of years. Some have been variant driven, but some clearly are indoor living, cold temperature, drier air with what we see with air conditioning, people clustering indoors because it gets so hot here. So we're wondering where that is, but I will tell you, at least right now with our crystal ball of a few weeks, it looks like we're in a pretty good place. So that's kind of data point number one. So if you're trying to protect yourself, your risk of getting infected is on the low end of what we've seen at any time during the 3 years right now. What we do also know is that none of the vaccines are, at this point, with all the variants that have come through, really great at preventing infection. They help, and certainly in the short period of time after you get a vaccine, they help a lot. What we know they help at, undoubtedly and dramatically, is helping prevent severe infection, helping prevent hospitalization. That effect seems to wane less than the effect of whether you get infected or not, but there's some waning of that as well. So that's a long-winded way to say you need to individualize this choice. I see absolutely no downside to getting another shot right now. There's every ability to do so, so there's no restriction on your ability to do so. I think it's most likely we'll have recommended shots, whether it's a different cocktail or not, unclear at this point, sometime in the fall. But I don't think you're probably going to see a big national recommendation about another booster now. But if you're elderly, if you're infirm, if you have lots of risk factors, if it were me, I'd get a booster, about 6 months or so after that last booster, just to get more antibodies flying around and to fight any waning. If you're going to put yourself in higher prevalence situations, and frankly, you don't want to screw up a trip around the world, why not have more antibodies flowing around and have that kind of 6 week window or so where you probably won't get infected because you've got lots of antibodies. So again, individualize. Certainly that's exactly what we are doing in our family. I got mine in September. I've not yet sought out a booster. Quite frankly, I don't have any international travel early coming up, and we're down low, so I'm going to wait and find a spot where I can protect myself during a bigger surge. So I hope that's helpful. I wish I could give you a definitive answer, but individualize, and certainly a very safe choice if that's what you choose to do. So with all of that, I want to thank each of you for being here today, being part of our Town Hall series. As always, I thank the Society for Leading Medicine and our chairs again. I want to thank Drs. Vrebeck and Takashima for being here. Fascinating topics that affect essentially everybody at some point, as well as Dr. Levin, who's been typing, I'm sure, furiously and answering lots of questions in the background. We will have another nice session, I think, in May, or end of April, I guess, and we're staying above the neck. So while we've done ears, nose, and throat, we're going to do eyes next. And so we're pretty simple that way, we think. And the last thing I want to say to my two colleagues here and to anybody else here on the phone, on the conference, and as well as all of you as you talk to people, this is Doctors Day today. So happy Doctors Day. Thank you for making Houston Methodist exceptional. And thank you to all the physicians out there. They are obviously the lifeblood of what we do, along with our nurses and other clinical individuals. So we're deeply appreciative of both of you. God bless everybody. We'll see you soon. Thank you.